When traditional medications stop working for advanced Parkinson's, deep brain stimulation becomes the clinical gold standard to help patients take back control. This is a serious, invasive procedure. It requires navigating the brain with pinpoint precision, while the patient is securely immobilized in a surgical frame. Securing a place in the operating room is just the first technical hurdle. The real strategic challenge is that surgeons aren't aiming for a single universal off switch for the disease. They have to choose between two distinct targets buried deep within the brain. Those two targets go by the clinical acronyms STN, short for the subthalamic nucleus, and GPI, the globus pallidus interna. Both spots are highly effective at quieting tremors and stiffness. The true consequence of this choice lies in the permanent lifestyle and cognitive trade-offs you will have to live with long after you leave the hospital. Naturally, anyone facing brain surgery goes looking for a clear answer. You want to open up the medical journals and find definitive proof that one target is objectively superior to the other. This flowchart shows researchers filtering hundreds of medical records to single out the most reliable studies comparing both targets. These trials faced intense quality checks. The consistent green marks here indicate a low risk of bias, ensuring the comparative data was completely reliable. The conclusion drawn from all that rigorous data is actually quite frustrating. There is no universal winner. What works perfectly for one person might be the wrong choice for someone else. Because the clinical trials can't hand us a single answer, the medical team has to stop asking which target is better overall and start asking which target matches your specific biology and daily life. Let's start the comparison with the STN target and what it does best. The STN is incredibly powerful at tackling the classic visible symptoms of Parkinson's. If you are struggling with severe tremors, slowness of movement, or muscle rigidity, this target provides massive physical relief. This chart illustrates a major secondary benefit. After an STN implant, you see a drastic drop in daily pills. As medication reliance falls, so do exhausting side effects, making STN attractive if your pill routine is a burden. On a technical level, stimulating the STN requires less electrical power, which significantly extends the battery life of your implanted device. A longer battery life means you won't have to go back into the operating room as often for replacement surgeries over your lifetime. The STN target gives you back your physical movement and breaks the cycle of constant medication. But those physical gains come with a specific cognitive vulnerability. The primary downside of choosing the STN target is a documented risk of cognitive decline following the surgery. The data shows a drop in specific frontal subcortical functions. Patients often experience a reduced attention span and a weakened working memory. Processing speed also takes a hit, along with what doctors call phonemic fluency, which is your brain's ability to quickly recall and produce specific words during a conversation. To be clear, this doesn't mean a sudden onset of severe dementia. However, the studies show a statistically significant decrease in cognitive sharpness when compared to the other surgical option. The powerful motor improvements of STN are tied directly to this elevated risk. If you are already dealing with memory issues, targeting the STN becomes a much riskier proposition. That brings us to the alternative target, the globus pallidus interna, or GPI. This radar chart shows how the GPI compares. It excels at cognitive preservation, actively protecting a patient's baseline global cognition and keeping learning and memory intact. It also has a distinct advantage in suppressing severe dyskinesia and painful muscle contractions, known as dystonia. For your neurology team, the GPI is easier and faster to program, allowing you to find comfort settings sooner. But the GPI comes with a heavy set of trade-offs. Unlike the STN, targeting the GPI will not allow you to significantly drop your daily medication. You will still be relying heavily on your pills. There is also an engineering cost. The GPI requires much higher voltage and frequency to work, which drains the device's battery substantially faster. Choosing the GPI means prioritizing your cognitive safety and controlling dyskinesia. In exchange, you accept the hassle of more medication and a shorter battery life. Making this choice requires objective, measurable baseline testing before you ever step foot in the operating room. Doctors rely on two critical assessments to build your profile: the UPDRS, which scores your physical motor symptoms, and the MoCA, which evaluates your cognitive health. These baseline scores feed into a clinical decision tree, branching downward to match your profile with the statistically favorable target. If your cognitive scores are robust and your goal is reducing severe tremors while shedding pill burden, the data routes you to the STN target. This mapping aligns the surgical choice with your clinical reality. It ensures the target selected is the one statistically most likely to meet your specific health needs and long-term goals. Conversely, if tests reveal cognitive vulnerabilities, or if you suffer heavily from medication-induced dyskinesia, the path shifts over to the GPI target. But taking the GPI route means accepting maintaining a high pill count and dealing with frequent battery replacements yourself. It's important to remember that both of these targets are highly successful. Either choice will relieve the physical symptoms of Parkinson's and improve your overall quality of life. The only real mistake is committing to a target that forces you to compromise on a part of your lifestyle you will not give up. Ultimately, you aren't searching for the objectively perfect brain target. You are simply choosing the specific set of compromises you are most comfortable living with.